inflammatory, endocrine, and so on and so forth. He will spell out the clinical approach. And over to Sherlock Holmes, Dr. Madhu.
Thank you, Dr. Sharma sir, for his kind introduction. Sharma is like a parent who always tells extra things about their children. Just like Sharma is also telling extra things about me, even though I do not deserve whatever half of what he has already said. Before my talk, I also like to express my gratitude and thanks to Dr. Sandhya Mitra and your team for giving me a chance to talk to you in this session. After hearing such a fantastic talk by Dr. was taken to a different level of syllabus. They joined together to the common nerve, divides into a dorsal primary rami and the ventral primary rami. The ventral primary rami forms a plexus and then forms a peripheral nerve which supplies the muscle. Okay, if you ask me what is meant by peripheral neuropathy, I do not know, because the reason I'll tell you why I said so. Is it affection of the peripheral nerves or the peripheral nervous system? If you talk about peripheral nervous system, it is that part of the nervous system outside the pia mater of the brain and spinal cord. That means that you include the dorsal ganglion cell, but not the anterior horn cell. But what about the anterior horn cell? Is it a part of CNS? The part of CNS. But you all know that anterior horn cell, that's all. So disease of the anterior horn cell mimics exactly the answer. So what is this peripheral nerve system? Again, I am mentioning the peripheral nerves only. The peripheral nerve is the one which comes distal to the plexus. If that is the definition, what about plexopathy, radiculopathy? Do they come under peripheral neuropathy? Don't they come under peripheral neuropathy? Obviously, yes, because clinical disorders of roots, plexus, nerves mimic each other. For example, if somebody comes to sensory loss in the little finger, it can be ulnar involvement or it can be due to a sciatic. So what in essence is, rather than defining what is the peripheral neuropathy at all, you must have an approach to a problem of a paralysis, which is LMN, or sensory loss due to a problem in the periphery. That is the basis of my talk today. So even the peripheral neuropathy suggests disease of the peripheral nerves, it should also include disease of the cells of origin of the motor and sensory and autonomic fibers, since the clinical presentation is similar. Plexopathy, motor peripheral neuropathy, manual junction. I think it's very simple and simple, but it's not that simple all the time. Think of a 23-year-old lady with progressive weakness of both the lower limbs followed by upper limbs for a period of 1 week with brisk DTR or downgoing pattern. So you are at a loss whether it is a pyramidal lesion, it's a myelopathy developing, or a GBS developing. Only time will prove, or without investigation, you can decide. So these problems sometimes arise. So in the initial phase, they always will be difficult. Now, once you've decided it is an element paralysis due to the features, it cannot conform to a nerve or a root. Some of the muscles, not all the muscles and nerves are affected. Some of the muscles, other nerves are affected. Such kind of and fasciculation. But again, for certain pitfalls. Classically, peripheral nerves are motor and sensory combined nerves, but some nerves are purely motor. For example, deep branches. A person, an older man coming to with wasting and weakness will be a motor neuron disease, but beware, does not have any senses. So you always find out whether this possibility has to be kept in mind before jumping to the diagnosis of anterior console disease. How to localize at the root level? They usually have, as already told, motor and sensory affection. And the weakness is the myotome distribution. You know what is a myotome? The muscle supplied by the particular distribution of the root. Nerve means the nerve supplies particular certain group of muscles. And segment pointing muscles are important. What is segment pointing muscles are? Some of the muscles are solely or wholly supplied by or largely supplied by one particular root. For example, EHL, extensor longus, is a segment pointing muscle of L5 root. So if you cannot think of an L5 root without affection of that muscle. So that is the L5 root is. We will not spend. There are other features like separated by a single root. There may be more than one root. So one root affection will not produce a significant atrophy at all. Secondly, monoradiculopathy seldom causes marked weakness of a single muscle or brain muscle. For example, dorsal nerve. It is coming from the root, the long thoracic nerve coming from the root, but not from the trunk. So it exactly mimics that root, but these two muscles will be spared in trunk lesion. On the other hand, when you diagnose a cord lesion of the brachial plexus, it does not conform to the pattern of root at all, because there is a plexus where some fibers go to the posterior division, some go to the anterior division. So here the pattern is that of that muscles, the nerves which arise from the particular cord. For example, if you want to diagnose a medial cord lesion, it should be affection of the ulnar nerve, medial division of the median nerve, medial cutaneous nerve, the forearm nerve. So that pattern it will take. Now come to the nerve lesion, the sensory motor affection, except those which are purely motor, and the muscle involvement and sensory loss is the distribution of the territory in the corresponding nerve. Here, one certain pitfalls you should be aware. In nerve lesion, you need not necessarily get all muscles separated by the nerve to be involved. For example, in early ulnar nerve lesion, the first muscle affected by the adductor of the little finger, so-called Wartenberg sign, the little finger will jut out like this. So that when the patient puts the hand in the pocket, only the little finger will come out. And the common peroneal parts, you may find that even though it supplies the peroneal, they may be spared. In anterior-introduced nerve, only muscle effect may be flexor pollicis longus. The sciatic nerve, these are certain pitfalls in diagnosing. Don't expect that all muscles can be equally involved in a nerve to one cranial nerve, or only some of the muscles within the supraorbital cranius. For example, look at one medial rectus, lateral rectus of one eye. It is not fitting with the nerve pattern. See, when it is third nerve, it operates the middle rectus, other muscle development. If a jaw opening is strong, jaw closure is weak. So both are separated by the fifth nerve, but here only some of the muscles are affected. That kind of pattern you get, again, consider the possibility of a manual injection. And other features like episodicity, fatigability, those things you know. Somebody comes to you like that, think of most likely the possibility of a myasthenia. When you diagnose myopathy, it's a symmetrical affection. Bilateral affection may not be symmetrical always, but usually symmetrical. And the most important thing is the selective group of muscles are affected, which does not conform to a nerve or a pattern, a root. Only proximal muscles are affected, only distal muscles are affected, or proximal upper limb and distal lower limb, like that kind of a scapuloperoneal distribution can affection can. What about sensory? A person can with numbers of say hand or foot. It will be difficult to say here, unlike human and element, where you can differentiate by looking at the reflexes, looking at the spasticity and things like that. In sensory, you cannot just differentiate whether its affection is as PNS or CNS. If a patient comes to you with numbness of the left foot, it could be due to lesion anywhere in the sensory pathway. It may be in the peripheral nerve, like in the case of foot numbness, peroneal nerve or sciatic nerve. Maybe in the sacral plexus, it may be the sensory ganglion, it may be in the L5S1 root, maybe the spinal tract to begin with, or maybe even the thalamus and cortex. As the lesion progresses only, you mean the sensory loss will extend to the full to the corresponding full extent of that particular. It can be in the root, the ganglion, it can be in the plexus, it can be in the nerve. And the localization where exactly is on this. For example, when the loss is in severe, like for example, the CAT extent field, the middle part forearm. So that's a dermatomal pattern. Distal symmetrical, both peripheral nerves are affected symmetrically and distally. So that pattern will help you to localize where the lesion is. Again, certain pitfalls you should be aware. It's a single root affection may not produce any loss because other roots are taking over the function. So you must know in C6 root, the sensory abnormality may be contained to the thumb. For example, in this prolapse, this radiculopathy is only numbness of the tip of the finger, L5, big toe, S1, both and big toe. So these are the areas first affected in that particular nerve. Now, how to localize? Then, if sometimes roots may be affected diffusely, not one root, bilaterally, symmetrically, or asymmetrically may affect it. Some in the case of a TB like that. Sometimes sensory roots alone may be affected, as in the case of chronic inflammatory sensory polyradiculopathy called CASP. Or sensory alone may be affected in ganglion neuronopathy. Here there is a pure sensory affection, an asymmetrical bilateral affection, and symptom depending upon which sensory ganglions are affected. Usually in the large fiber ganglion, they come to you with ataxia, neuropathy, depending upon mononeuropathy, modern multiple asymmetric neuropathy. Again, you must be aware pitfalls in diagnosing sensory. So, for example, in the carpal syndrome, the sensory loss may not spend the entire distribution may control to the finger. And look at the variation of the areas separated by the radial nerve. It may be from the small area of the web space to the area complete area separated with the radial. And this, I think, this I will skip because to save the time and see the points. Then another pitfall you should remember is that in nerve root lesion, we can mimic a central nervous system lesion. For example, a thalamic lesion or a parietal lesion sometimes can have paresthesia confined to the periphery in something mimicking a peripheral nerve radicular distribution. So called pseudo radicular sensory loss. Now, if you find a person with both motor and sensory affected, then you don't think of pure sensory neuron, ganglion neuron. You don't think of a pure myelogenic muscle disease. Don't think of anticonceptive neuron. Think of radiculopathy, plexus, and peripheral, which are both combined motor. Then, what is this radicular neuropathy? Say very often when you present a GBS patient with this thing, your examiner wonders what is this. With bilateral affection of both proximal and distal muscles, it's still sensitive. But this same can occur with a person who has got multiple nerves involvement. It will be difficult to differentiate this from diffuse polyneuropathy, where proximal motor nerves are also affected. The pattern is same. For example, GBS, thickly myelinated fibers being proximal nerve, they are affected more. So proximal nerves will be affected more in GBS. Unlike a toxic neuropathy, where the distal nerves are affected. So it is the pathology that determines whether proximal nerves are more affected or not. It is not because the radicular neuropathy is not there. This term unfortunately came because pathologically you find infiltration in the roots. However, your examiner wants this term for GBS, so use that term radicular neuropathy. If autonomic nervous system is affected, it may be a pure autonomic nervous system or part of the peripheral neuropathy. Obviously, it not be affected in pure anterior constant or sensory ganglion. If it is there, you can rule out this possibility. And it usually indicates a peripheral nerve lesion. Suppose you had a problem sometime differentiating a quadriconal lesion from a lumbosacral plexopathy. Quadriconal lesion will not affect the sympathetic nervous system. It will not produce edema or trophic changes because quadriconal does not carry sympathetic fibers. First affection is in the immediate it is an axonopathy because axonopathy, the distalmost part suffers first. So the longest axon get affected. Rarely this pattern can also occur in hereditary neuronopathies like hereditary SMA and demyelinating neuropathy do not produce such a kind of pattern except very rarely 2-3 conditions like DATS variety and hereditary and dependent neuropathies. But generally, all these demyelinating neuropathies like ADP and all, they do not produce a pattern. I think causes if it is motor, the distal neuropathy, sensory If sensory affection may be large fiber or a small fiber. Patients large fiber means they present with cotton full sensation, sensory ataxia. The causes, the axonal type may be metabolic, nutritional, toxin and drugs, demyelinating, DATs. Then small fiber neuropathy means they come with painful dysesthetic sensations such as by which apart from place where now certain evolution can include the acute, subacute, or chronic. If it's acute, days to 4 weeks, subacute means 4 to 8 weeks, chronic means more than 8 weeks. Acute causes may be apoplectic, abrupt, or sudden, think of vasculitic mononeurus multiplex or idiopathic myositis. Days to weeks, think of ADP or GBS porphyria, acute toxic exposure, proximal diabetic neuropathy, paraneoplastic sensory ganglion neuropathy. Chronic weeks to months, metabolic and toxic like diabetic polyneuropathy, CADP, and idiopathy. Years things of hereditary neuropathy, deformities, gait abnormalities, and history of other organ dysfunction. These all give clue to the etiology of the neuropathy. The dermatologic clues like vasculitic ulcers, atopic ventilation, there's subacute combined degeneration, your to telltale evidence of hereditary neuropathy. This is favor anesthesia. This is dermatose, the inverted champagne bottle appearance in hereditary neuropathy. Now I'll take five more minutes of your time. Sum up a pattern recognition in peripheral neuropathy. If you are not listened to my talk so far, at least listen to this part, but this will give you a rapid approach to what you're dealing with. Sensory and motor affection. Okay. Now, the motor affection, if you have asymmetrical distal weakness, find out whether there's human findings are present or without human findings. If human findings, only one diagnosis. Hereditary like the pattern, the symmetrical disloss, and human findings. There are conditions like vitamin B12 deficiency, HIV infections, like vascular myelopathy, severe hepatic disease. In certain rare inherited disease like leukodystrophy, which you can ignore. If you find the sensory loss is asymmetrical, so far we talked about the three patterns of symmetrical. We are talking about an asymmetrical affected sensory. Obviously, it cannot be symmetrical involved, with multiple nerves affected. There, the etiology could be vasculitis, which does not produce a symmetrical involvement. Hereditary liability to pressure palsy, and one variety of a demyelination neuropathy. Just like a modern is multiple. Only thing the etiology is that the demyelination cause. And infection like leprosy, and finish in 1 minute. Leprosy, Lyme, sarcoid, and HIV, or single nerve involvement, think of compressive mononeuropathy and radiculopathy. Then asymmetrical proximal and distal weakness with sensory loss. Think of polyradiculopathy and plexopathy due to diabetic amyotrophy, meningeal carcinomatosis, lymphomatosis, sarcoid amyloidosis. Idiopathic, think of neurologic amyotrophy. And hereditary means hereditary liability to pressure palsy. Then the pattern.
Wonderfully, you have covered the whole thing of neuropathy seen clinically in our population.
In our population, I had not seen one. Literature says yes, copper deficiency can present just like a subacute combined degeneration. The other thing, what he said, I forgot.
Copper deficiency and vitamin deficiency.
Vitamin deficiency is very, very common. No doubt about it. Very, in our sector, vitamin deficiency is extremely common. But we are not looking for it.
Yes. The third one is approximately what percentage of loss of sensation or power is required for the patient patient to patient to realize that they have loss of sensation of power?
For power, more than 50% of the anti-neuron cell domain. Putting another words, you have got 100 anti-neuron cells. You can have a normal power with the rest 50% of the anti-neuron cells. But the case of sensory, it depends upon either you can depends upon the type of fiber affected. If touch fibers are affected, any amount can produce decreased sensation. Need not be that all fibers should be lost. If all fibers are lost, means total anesthesia will be there. Some are affected depending upon the number of fiber lost. The sensory loss is graded depending upon that. Motor fibers, I can told you, more than 50%.
Okay, thank you. I will just ask one question, not in the chat box. The patient with the posterior column sensor loss, which toe you will choose, big toe or second or third or other toes?
No, that it's a good question. That depends upon where you suspect lesion to be. For example, if it's a parietal is your suspect site of lesion. I think this we have discussed with Dr. many times before also. In fact, he is the one who told me first this particular. But this is not applicable for other sites of lesion. For example, in the case of peripheral neuropathy, obviously you are for the distalmost part of the feet, the big toe or the little toe should be affected. If you think of an ulnar neuropathy, look for the sensory of the little finger. So that's the thing. Depending upon what you suspect, you look. If you suspect a C6 radiculopathy, don't look for anywhere else. Look for your index finger. So where to look, what should be affected first, depending upon what you suspect clinically.
Just one more question from Cyril Jacob. Sir, could you share with us the most interesting case of peripheral neuropathy cause we have evaluated your vast clinical experience? Most interesting, single experience. I think that will be the last question. Time is running short.
The most interesting case I detected was a person who came with ataxia. His peripheral reflexes are all normal. But electrophysiologically, he had peripheral involvement. But his culprit was in the gracilis column. The hyperintensity was in the dorsal column, the uppermost part, and it was a vitamin B12 deficiency. That is the funniest case I detected.
How can you manage diabetic ataxia?
In diabetic retinopathy, there are two types. One is due to the metabolic involvement, where unfortunately there is no treatment. Once it is, you had it for life. On the other hand, if it is ataxia due to a multiplex like pattern, or diabetic amyotrophy, then you can get improvement. Some of the amyotrophy may be asymmetrical, can affect proximal and distally in a patchy distribution. That may improve. Similarly, in one entity called CADP is more prone to occur in diabetic patients. That also will improve with treatment. The conventional SADA garden variety of a diabetic retinopathy produces sensory ataxia. That will not improve.
Thank you, Madhusooothanan. We had a wonderful discussion. Thank you so much because running short of time. Otherwise, I could ask few more questions. Thank you so much for the excellent clinical approach. Thanks a lot.
Thank you so much.
Thank you, Madhu sir, for that excellent presentation, covering the length and breadth and the depths of peripheral neuropathy in such a meticulous and succinctly organized manner. Thank you so much, Sharma sir, for chairing the session. Thank you to all the delegates who are sending us your questions. Please do send us your questions because that enlivens the entire program.